Hello.
Hello. Hello, sir.
So tell me, in which cases you cannot do a pneumoretinopexy?
Pneumoretinopexy you cannot do. It is contraindicated if the break is inferior, and if the break are multiple breaks are there, and if the breaks are more than 3 clock hours, inferior retinal breaks, and if the breaks is associated with the severe proliferative vitreoretinopathy changes,
Very
then
nice.
in that case, I will not like to do
And as you said, if the
numerator.
patient is traveling and is not suitable or not ready to maintain posture, okay.
Hmm.
So now in this you inject gas, and what do you do followed by that?
Um, After that, I will explain the position about face positioning and all that, and after that,
Yes.
I will call the patient for follow-up.
No. What is the other thing after you have injected gas? So gas is
Uh,
tamponade. What is next you need to do?
uh, I will see retina is attached or not. Brake is completely
How will the brake
is
be
it
attached in one day? How much are you
uh,
injecting?
quantity ml? I don't know, sir.
You are injecting 0.3 ml only. You are waiting for it gas to expand.
Hmm.
Okay.
Uh, yeah,
So so
I
so that is
did
very
understand question, sir.
no. This what is the procedure for doing pneumoretinopexy?
Uh, Procedure, sir. I will inject the gas, and then
What will be? How will you do the retinopexy?
yeah, with the help of gas, I will inject in
How will
27
you
gauge
do
needle.
retinopexy?
Uh, like sir, in the like it's OPD procedure. In OPD, with the help of 27 gauge needle.
What are the two main principles for attaching retina?
Uh, like First, surface tension and buoyancy. The surface tension
No,
of the property
no.
which cause
What you need to do to attach any retina?
tamponade,
And
and uh, buoyancy, buoyancy, buoyant,
tamponade, and what else do you need, Amol?
uh, uh, positioning.
Other than that, what you need to do, not the what the patient needs to do.
Uh, don't know, sir, don't know.
You will have to do cryo or laser.
Yeah, yes, sir, yes, sir, yes,
I
sir.
told you, na, you have to do two things. One is that you have to do put a tamponade. Second thing is you have to do a retinopexy for any procedure.
Yes, sir, yes, sir. Yes.
So how will you treat if patient is not ready for pneumoretinopexy, then what you will do?
Uh, I will go for scleral buckle, sir. Scleral buckle. I
Okay.
will,
So how will you go about doing scleral buckling?
like there are two options. Like here it is single break, so I will go for segmental buckle, sir.
Very nice.
Uh, and So procedure you're asking like
Yeah, how will you put the buckle?
uh, first 360 degree. No, there is some conjunctival peritomy I will do superiorly. Superiorly, I will do conjunctival peritomy. After that, uh, I will expose the superior rectus, and then then I will do the IDO, and I will see where is the location of break, and then I will make a scleral flap, two parallel scleral flaps for the insertion of the segmental buccal, and then I will see then I will attach the segmental buccal, and I will see IDO, is it indenting and indenting the retina, and is it attaching or not, also is it covering break or not, like that I will see. If it is indenting, then uh, properly, then I would like to suture that buccal part, and then I would like to go closer.
Okay. Anything else you would like to do?
Um, like cryopexy, I would like to do.
Yes. So you have to first do a cryopexy. Okay. And then you have to
Yes.
put the buckle there.
Yes.
Okay. So what are the different procedures for doing buckle? What are the different types, methods for doing the buckle?
Circumferential and segmental.
Very nice.
Circumferential will do 360 degree,
Hmm.
like along the all muscles, superior rectus, inferior rectus, medial rectus, and lateral rectus, uh,
Mhm.
and uh, uh, and one is a segmental. That, and,
So what is else? If there is too much fluid, what you will do?
I will do SRF drainage.
Very nice.
Uh, like SRF drainage, I would like to do like if the bullous RD is there or long-standing
Very
RD
nice.
is there
What
with
are the
viscous.
complications?
The complications of SRF drainage could be like it depend upon which procedure you are doing, like two procedure, prying and cut down. So if you are going to external way, so they can be choroidal hemorrhage, or they can be vitreous incarceration, or the iatrogenic retinal break formation, raised intraocular pressure, or they can be a subretinal bleed, subretinal hemorrhage, uh, or infection could be there, bleeding could be there from the site.
Okay.
And, yes.
Very nice. What are the materials of the buckle?
Silicon, silicon, the material I will use silicon, and there's a silicon tire and belt.
Huh?
Silicon is the material.
Silicon
I
tire
would like
is
to.
there, silicon belt is there, very nice. But what are the different types of silicon which we can use?
Uh, I don't know.
Dr. Sneha, you would like to tell me what are the different types of buckle? Dr. Sneha, you are there?
Yes.
Yeah. Would you like to tell me?
Sorry, I didn't hear you. What was the question?
Yeah, different types of buckle.
Different types of buckle.
Yeah.
270. I'm not sure.
No, not the number.
The band
Yeah. But he has told that there is
buckle and belt buckle. So segmental buckle.
No. See, you need to understand band, belt is the same thing. Okay. Someone will say I am wearing a hairband. Someone will say I am wearing a hair belt. It is the same thing. So band and belt is the same thing. Okay. So there can be either band or there can be either tire. Okay.
Hmm.
Now there is different material of buckle. Okay. Amol, any guesses?
Silicone.
Uh, silicone one I know.
Yes, silicon only.
Teflon.
But if it is not very hard, if it is not very
PMMA, no, not PMMA.
no, something which can absorb, something which is porous.
This hydroxyapatite.
No. मेरे को पता नहीं रहेगा तो भी. Either it can be solid silicon or it can be
sutures like.
suture नहीं. कोई चीज को उसको पानी में डालो तो it absorbs water. What is that? Dr. Sneha?
I'm not heard about it. Not sure.
Yeah, so either it can be a solid silicon or it can be a sponge. Okay. So there are two types of basically explants which we are using. Okay, one is a solid silicon rubber or it can be a sponge.
So it's a silicone only. Both.
Yes, silicon only, but it is a sponge. Okay, so it is a sponge and this is a solid. So what are the advantages or rather disadvantage? Of the sponge? Why people or why you are not seeing too much of sponge in your practice or in your places where you are being trained?
Because I mean, it will not cause like proper indentation for longer time. That
No,
could be one
because of sponge, it can be that it can lead to infection. Okay, because in those porous material, there can be bacteria. So that is one thing. Okay. And commonly we are using is solid silicon.
Yeah.
Okay. So what are the complications, intra-op complications of doing a scleral buckle?
Intra complication could be like there can be a superior muscle hematoma. There
Which
can be
hematoma?
muscle hematoma.
Okay.
Muscle hematoma could be there, or they can be bleed from. There could be scleral perforation.
So there
Or
can
they
be
can be
bleeding. That is one thing. There can be perforation. Perforation will happen at which step, Dr. Sneha?
Must again I got disconnected. Complication of scleral buckle.
No, Dr. Amol said that there can be scleral perforation. So scleral perforation will happen at which step?
Why would scleral perforation happen during passing?
So because we are doing sutures, okay. So if the sutures
Okay,
go and through, there will be perforation. Okay. So basically you will pierce the sclera and you will go into the choroid and you may even go into the subretinal space and you may go even into the vitreous. Okay. So what is the depth of the suture, Dr. Amol?
depth, sir, I think 1/3, like so 1/3 will be.
Yeah, so it is a partial thickness. We don't take full thickness. And what is the type of needle?
Type of needle would be
Is it a
cutting,
straight
like
needle?
cutting.
Cut,
Dr.
cutting,
Sneha, yeah. What type of needle it is?
curved cutting.
Do we have to cut something? Where do we have to cut?
Is it blunt, sir? Blunt.
So it is known as, what is a blunt instrument which you use anywhere? What is it known as?
Hockey stick, no? Yeah.
No, hockey stick
Okay.
is used for what?
For making flap, scleral flap.
Yeah, so we are taking sutures.
Round,
Dr. Sneha?
round.
No, I don't know.
Okay, who is the father of retinal surgery?
I know this name.
Very nice.
That person who discovered the IDO.
Who was the person?
Charles. No.
Charles Shepens. Very nice. So
Charles
there
Shepens.
is, see, he didn't discover the IDO. He popularized using binocular indirect ophthalmoscopy. Okay. He was the one who started popularizing it. But who was the person who is the father of retinal detachment surgery? Dr. Sneha? So it is Jules Gonin.
Yeah, Jules Gonin. Yeah.
Okay. So what he said was that if you have to close or if you have to treat an RD, you have to treat the break. Okay. He said that the breaks are responsible for the RD. Before him, it was thought that the RD's retinal detachment leads to the formation of break. But he was the person, he did biopsy of a lot of eyes and he found that all the cases of RDs had a retinal break. So he came to the conclusion that break is the cause of RD. And if you treat the break, you treat the RD. And that is what we follow in any procedure, whether we are doing pneumoretinopexy, whether we are doing scleral buckle, or we are doing vitrectomy. We have to treat the break. Okay. So when we are doing pneumoretinopexy, so as I said, there are two things which we are doing. By one way is we are pushing the retina back, and the other way we are attaching the retina there permanently. So when we do pneumoretinopexy, by pushing gas, the retina is pushed back. Now it will not stay there for the rest of the life. So that is why we do a retinopexy procedure there. We do a cryo, we do a laser. When we do buckle, we put a buckle, so that will indent the retina and it will bring the subretinal space close to the neurosurgical retina. Now it should remain permanently because your sutures may get loose. You may want to remove the buckle, so you will do a cryo there. Same thing with vitrectomy. You will go inside, remove the vitreous. You will do endolaser around the break and you will put oil or gas. Okay. Yes. So the needle is a spatulated needle.
Yeah.
Okay. It has to be a spatulated needle because it should not cause trauma to the scleral fibers. This needle was discovered by whom? This is not important. Okay. But it was linked.
What's the length of the needle? We have to take approximately the length,
See, the
buckle
length
we
of the
pass.
bite is there. Okay. See, the length of the bite will depend on the size of the break and the size of the buckle. Okay. So buckle, you have to be sure that the tip of the or the posterior portion of the buckle is at least on the summit of the buckle or on the apex of the buckle. Okay. And the anterior most portion rests on the buckle. Then only your buckle will fit. So these have to cross 2 millimeter beyond that. Okay, so if it is posterior, you have to do more length. If it is anterior, you can do less length. Okay.
Can you
But
repeat it? No, I didn't get
basically,
the
your brake has to be covered by the buckle.
bucket.
Yeah. So the anterior most, posterior most part of the brake should rest on the buckle. That is the portion where it is
Posted.
having the major this convexity or concavity. Okay, whichever buckle you are using, whether you are using asymmetrical buckle. So, and the anterior margins also should be covered by the anterior margin of the buckle. So then only your buckle will be this successful. Otherwise your buckle will fail. So you have to localize this when you do a surgery. You have to mark these areas. Okay. And then you have to put a buckle there. Okay. When you are using a segmental buckle, it is the suture length which will define the indentation. Okay. When you are using a circumferential buckle, okay, that means how tightening, how much you are tightening the buckle, it will depend on that.
Okay.
Okay. So, so what are the other complications will happen during buckle?
Like introp complication, I told, sir.
Yeah,
The,
introp.
like scleral perforation, then there can be hypotony.
Why will there be hypotony?
If there is a like so much pressure is there and scleral perforation is there, so that can cause hypotony.
So
And if
scleral perforation is there, na?
yeah,
So why, what is the next complication? One is scleral perforation. Next.
intraoperative complications, sir.
Yeah.
There can be a iatrogenic retinal break.
Why?
Because of like taking suture during taking suture or something like that, that can cause.
You mean to say the
If it is deep.
suture went through and through the retina?
Yeah. So,
Okay. Next.
like anterior segment ischemia would be there, but that would be post-op.
Yeah, Dr. Sneha, would you like to add something for intra-op complication?
It can cause muscle disinsertion.
Okay. Muscle disinsertion is very rare, but if the break is there and you need to do, if it is a traumatic RD and you need to check for this, then you may disinsert the muscle. But yes, at times, if it is very atraumatic handling, you can cause trauma to the muscle. Other than that, very important thing.
Yes.
Like you can miss the break. Like
That is will be the causes for failure, not a complication of the. So, how are you going to localize the break, Dr. Sneha?
We can do intraoperative indirect ophthalmoscopy, and we can localize
Yes.
the break during
And what is the other way you
surgery.
can do if you don't like to do indirect ophthalmoscopy?
so with the help of link off tool.
No, is there any way to visualize the fundus through microscope?
Like with biome lens? No.
Yes. Yeah. So you will use a chandelier light. Okay.
Yeah.
So you will do either a chandelier assisted buckle or you will do a indirect ophthalmoscopy assisted buckle. In both the cases, the cornea has to be very clear. Whenever you will tie the buckle, the IOP will rise and there will be corneal edema. Okay, so this is very important complication, and this is one complication which examiners want you to tell. Okay. So corneal edema, corneal haze is one thing. The pupil can go small.
Hmm.
Okay. And as you said,
Yes.
there can be bleeding. Okay. Anterior
But
segment
sir,
ischemia will always happen in a late
sir,
complication.
I have a doubt. Like, why corneal edema occur? And corneal edema can occur because of like IOP, but
Yeah.
like you are doing scleral like procedure, no? So
Yeah.
cornea is not involving. So like,
Cornea is not involving. It is the IOP which is increasing.
oh, yes,
Okay.
yes.
Other thing, very important thing is you look inside the retina and you see something pulsating.
Yeah, the optic disc, uh,
What do you see
optic
pulsating?
optic disc, you will see, and the central retinal artery.
Yeah. So what does it suggest?
Uh,
Is it normal to
uh,
see pulsations?
yeah, pulsations are normal, sir.
Dr. Sneha?
It's normal in 30% patients, but if
Dr.
the IOP is
Rahul,
very high,
would you like to tell me, are these arterial pulsations seen in 30% or less than that? See, this is where you get caught. So it is spontaneous venous pulsations which are seen in 30% of the patients. Arterial pulsations means there is some problem. Okay. So if the central retinal artery is pulsating, that means there is ischemia. That means it is going into central retinal artery occlusion. You leave the patient like that for a few hours and that's it. The retina will be attached, but patient will not see anything.
Oh.
Okay. So this is a trap question. They will always ask you, is it normal or is it abnormal? Even if you don't tell them. Okay. So 30% it is
okay,
always spontaneous venous pulsation, not arterial pulsation.
okay.
Okay. In which cases it will be absent, spontaneous venous pulsation? Or
Papillary edema.
very nice. So in papillary edema, it may be absent. Okay. Yeah. So central retinal artery occlusion is also one of the major intra-op complications and you have to check for that. Okay. What are the late complications? You said anterior
Late,
segment ischemia. What?
yeah, they can be like diplopia could be there, or
Very nice.
they can be raised intraocular pressure or
Yes.
anterior segment ischemia.
So
Uh,
what are the this risk factors for anterior segment ischemia, Dr. Sneha?
Um, more than three muscles of if we operate on more than three muscles at the same time.
So
That's
see, we are not operating squint, na, so we are not operating on muscles, right?
yeah.
So this is we should not use this term. When we talk about squint, we say, are two muscles operated, three muscles. Okay. So we have to, it is about the quadrants. Okay.
Okay.
Yeah. So if it is more than 270 degrees, so you should not put a tire for more than 270 degrees. Segmental buckle of more than 270 degrees will lead to anterior segment ischemia.
Okay.
So do we do a 360-degree buckle ever?
no, sir.
Dr. Sneha?
I think we do.
Yes. So we do a 360-degree band. We don't do a 360-degree tire. We don't do a 360-degree segmental buckle.
Segment.
Okay. So bands are smaller. There will be 2 centimeter, 2.5, 2 mm, 2.5 mm. Okay. Or 3 mm. But the tires are bigger. There can be 7 mm, 8 mm, 9 mm. Okay. So they are to be avoided. Okay. So you can do a encirclage. This
Yes.
is okay. Other name for doing a 360-degree Band buckle is encirclage.
Encirclage.
Okay.
Okay.
And what sutures do we use?
Like absorbable.
Very nice. Absorbable. So absorbable will dissolve in how much time, Dr. Sneha? Dr. Amol?
Sir, it will take like 3 to 6 months. Like, I'm not sure,
ये
but
कौन सा
3 to
सूचर
6
है? 3
months.
to 6 months तक चलता है.
I'm not sure, sir. Like how much duration?
Dr. Sneha? So you use
Not
non-absorbable
in,
sutures.
not, yeah.
Okay. It is very important that you use non-absorbable suture.
None of the
Okay. Which all sutures do you use? Names of the suture?
Proline, or
We use proline.
yeah, proline.
Hmm?
Yeah, proline. That I'm not sure about the much, but
Where are
proline
you
could be.
using proline? In which surgery are we using proline? What are the type of suture? Matlab, what is the characteristic of the suture? It should be there.
It should be non-absorbable. Like
Very nice. Second,
one is a non-absorbable and one is absorbable. So non-absorbable proline is there.
okay. So what is the other characteristic of sutures, Dr. Sneha? What all sutures you can use?
Proline, nylon, like
Okay.
or
So it has to be a braided suture. Okay. Commonly which we are using is polyester. Okay. Or ethibond, 50 ethibond, polyester, mersilk. Okay. These are the sutures which are to be used. Okay. We are not
Mersilk is absorbable, I think.
mercilin, I meant. अब मेरा एग्जाम मत
Mersil,
लो रे.
I think sir, it's yeah, I will check.
Yeah. Okay, so basically it has to be 50 polyester and braided. Okay, why braided? Where do we use
No.
proline?
Proline like for
Which
skin,
surgery?
any lead surgery like you can use
Which
after the
lid
retention,
surgery?
like LPSR resection, you can, or during
LPSR we are using proline.
or skin.
Dr. Sneha, where do we use proline?
Sir, absorbable we use inside like Vicryl, but
Proline we are using in cases where we have to do a secondary IOL. Okay.
yeah, SFIL.
Yeah. So we are suturing the conjunctiva with absorbable
Vicryl.
suture.
Yeah.
Okay. And what about now vitrectomy? How do we do
Yeah,
vitrectomy?
vitrectomy, like first I would like to look at three port.
Very
So
nice.
there are different types of different gauges, like 20 gauge, 23 gauge, 24, 25 gauge. There are different
No,
gauges.
no, इतना मत ऐसे मत निकलो. Which all gauges are there?
20, 23, 24, 25.
nahi.
Like,
So there is 20.
Sorry.
Yeah, yes, doctor, you can tell me 20 then.
Sorry, I just joined.
Okay, so there is 20.
Vitrectomy 23, 25, 27.
Yes. Okay, 24
Okay.
नहीं है.
oh, sorry.
हाँ, ऐसे फटाफट नहीं बोल देना है.
Yeah.
नहीं, 23 बोला उतना भी काफी है. Okay.
Yeah.
So yeah, what do we do?
So first that I would like to make the 3 ports.
No,
One
no,
port
well,
for
simple. What you will do in this surgery? You have made the ports, 3 ports. Next,
after that I will do first like vitrectomy, like central vitreous part should be like cutted, and after
okay, you
that
have done core vitrectomy.
then I will go like then I will induce the PVD so that there should
What
not
is the
be
full
any
form of PVD?
posterior vitreous detachment.
Very nice. Then,
Uh, I would stuck the posterior vitreous highlight face, and I will attach all. I will remove all the adhesions so that there should not be any secondary traction during the any intraoperative procedure.
yes.
Then then I would like to remove. Is there any like any membranes like
This,
fibrous
how are you
membranes?
setting the artery, doctor? There is retinal detachment, right? The retina is
Yeah.
detached. You have removed the vitreous. The retina is still floating. How is the retina going to attach to the RP?
Yeah. Then after doing vitrectomy and after inducing the PVD, I would like to induce like I would like to inject the silicone oil, and then the laser over the
So what
break
you will
size.
do is now
Fluid air.
yes. Okay. In fluid air exchange, what is your objective, doctor?
Like fluid air.
You are
Like it.
exchanging air with fluid. Okay. अंदर विट्रियस में कैविटी में क्या है? पानी है. You are
Yeah.
replacing with air.
So it is actually doing intraoperative tamponade.
No, but what
No, yes.
what is it achieving? तुमको विट्रियस कैविटी से तो पानी नहीं निकालना है ना. तुमको पानी कहाँ से निकालना है?
SRF drainage.
Yes. So
They're draining
basically
SRF.
you are doing SRF drainage by doing a fluid air exchange.
Yeah.
Okay.
Yes, yes.
So there are 2 methods. Either it can be active, where you are sucking out the fluid, or it can be passive by doing a flute needle. Okay. Basically, this is more than enough for ye. It has to be a active procedure or passive. Once the fluid is removed, the retina will settle back on the RP. Okay, now
Yeah.
what you will do? You will put
Then I
the
will.
yes.
Like I would put the buckle.
No, you are doing
No.
vitrectomy
Yeah.
now.
Yeah. Sorry, sir. Then I will inject the silicone oil.
Can you, if I don't want to put silicone oil, can I put something else?
Like PFCL.
You would like to put PFCL? Retina is attached now.
Then I would like to do laser like for the retinal break.
Absolutely. But you would like to inject something else instead of silicone oil? You
Fluid.
can put any gas.
Air. Oh, sorry,
No.
gas.
Yeah.
Any
So
gas.
never use air in retina. Okay. It is always
Yeah.
gas. Okay. As long as you are DNB, we are only putting gas.